Good morning. I'm Alexis Del Cid in for Jessica Lovell. Welcome to the Morning Medical Update. 35 years ago, Prozac hit the market, and it changed how doctors and patients approach depression. Today we're asking, will magic mushrooms, MDMA, and other psychedelic drugs lead to a similar revolution? What drugs are already approved by the FDA? Which drugs are coming up for approval in the near future? And what do these drugs really do to our brains? Whether the drugs are approved or not, psychedelic use is up. This graph is from a study funded by the National Institutes of Health. So if you follow that red line, it shows that in 2021, 8% of young adults ages 19 to 30 reported using a hallucinogen in the past year, significantly higher than 5 or 10 years ago. So let's learn from someone who's already prescribing psychedelic drugs in his clinic, Dr. Tyler Chervested. Dr. Chervested, thank you for being here.
Yeah, good morning.
He's a psychiatrist and director of the Comprehensive Depression Assessment and Treatment Clinic here at the health system. You're also the editor-in-chief of the Journal of Psychedelic Psychiatry. So I suppose we should just start with the term psychedelic drugs. It carries a lot of baggage, depending on the decade you were born in,
right,
and what you learned then. Some people immediately think of the 1960s and 70s, stories of people suffering damaging hallucinations, jumping out of a window or staring at the sun until they go blind. Some people associate them with raves and clubs. So Dr. Chervested, what's correct and what's incorrect about the stigma surrounding psychedelics?
Yeah, so I think the stigma with psychedelics really comes down to the fact that some of those reports happened while patients were actually on psychedelic drugs. Psychedelic drugs intrinsically are not going to cause people to lose their mind or go crazy. They can be abused, and so if they're taken in the wrong environment, you're going to notice that people will do things that they wouldn't typically do, and that might result in harm or destruction of property or imminent life-threatening events that they might encounter themselves. But by and large, the psychedelic drugs aren't causing that. They're just in an altered state of consciousness, and that's putting them in this situation. So psychedelics really just means mind manifesting, and so it causes things to crop up in your mind that you normally wouldn't do, and that has an underlying mechanism that's a resultant of the drugs. But the drugs themselves are actually not addictive. They're actually anti-addictive, so the more you take the drugs, the lower the response you get, and eventually you get no response. But they are abusable if you take them in the wrong environment or the wrong setting.
And when it comes to the stigma and the very real dangers that can happen if you're not taking it under a doctor's prescription in the right way, does that stigma and that push and pull slow down the research?
It definitely did. So I think wide-scale public use of psychedelic drugs during the 1970s caused a severe backlash, and that basically shut down all research on drugs from basically 1971 until about 1985 when MDMA was outlawed, and then shortly after 1985 and MDMA being outlawed and added to the Schedule I substances, we basically had a resurgence of research within about 5 years, and then it really hit the ground in 2000 where we started to look into things like ketamine, and then Johns Hopkins opened up a psychedelic center in 2005, 2006 and started to look at psilocybin or magic mushrooms. MDMA has been out there with MAPS and is ongoing for PTSD trials too. And so over the last 15, 20, 25 years, we've seen a resurgence of medicalized research to look and say, what do these drugs actually do for us? How do they work? And then what are the benefits or what are the good use cases for them?
And there are classic psychedelic drugs. So to break it down for you, we have the Psilocybin, which is from mushrooms, mescaline from cacti, and LSD. None of those are approved for medical use yet, correct?
Correct. Probably the closest one to being approved is going to be psilocybin. So psilocybin's probably going to be out in 2025 or 2026 if everything goes according to plan with the clinical trials. So. And
then psychedelic can also apply to ketamine or MDMA.
Yeah. So ketamine and MDMA are psychedelic adjacent. They're kind of psychedelic-like drugs. They don't have the exact same receptor binding or profile that we see with LSD or psilocybin or DMT or mescaline. And so they have a little bit more indirect kind of psychedelic properties. So they're more of dissociative drugs or empathogens in the case of MDMA, where people feel more empathy than they do like interconnectedness. There's a whole literature on this that kind of parses these out, but you can think of them as psychedelic adjacent or in that psychedelic family.
What kinds of things are being treated with these drugs?
So right now, ketamine is the only one that's legally approved to treat. So we treat treatment-resistant depression with esketamine, or Spravato is kind of the brand name for it. For IV ketamine, we use that for bipolar depression in addition to unipolar depression, and then you'll find a whole bunch of pop-up clinics out there treating pretty much everything else, PTSD, generalized anxiety. We don't have great indications for those things. Basically, the two major indications we have is treatment-resistant depression and acute suicidality. So acute suicidality, we use kind of infusions or short-term short-term treatments to kind of abort that suicidal episode,
Right.
And then more for long-term management, we're using it to treat treatment-resistant depression with ketamine. MDMA is going to be out later this year, hopefully. We're hoping August, September, and that's hopefully going to be approved for PTSD. The MAPS Association has worked a ton with the VA administration to do studies there on combat vets, and so we're hoping that that's going to lead to approval for PTSD, and so that'll be kind of the first psychedelic to make it onto the scene. Hopefully by mid-August we'll get approval, and then it'll be out for use by the end of the year, maybe early 2025.
Something to give combat veterans relief. What is happening inside the brain when someone uses a psychedelic?
Yeah, so psychedelics bind, the classical psychedelics, psilocybin, LSD, mescaline, DMT, they bind to the serotonin receptor 5-HT2A, and basically what they do is they bind so tightly that they turn on that receptor continually, and how that receptor influences the brain is basically you have a default mode network in your brain, so that's like your autopilot. It's how you would function normally every day. And so one of the analogies I use here is that imagine you drove down a dirt road every day continually. Eventually you would get ruts in that dirt road. And so those ruts are basically your neural networks that you establish in your brain. And so the brain wants to conserve as much as energy as possible. And so it will funnel down the amount of neuronal activity to as narrow a set of neuronal connections as possible. And so it's very hard to deviate out of those ruts per se once you've done something. So for a depressed person, you actually have a circuit in your brain that is firing every time you're in a depressed state. And the longer you're in that depressed state, the longer and stronger that connection gets. And so basically it's like, again, driving down that dirt road every day, and those ruts get deeper and deeper and deeper. And so what psychedelics do is they basically, it's like taking a road grader. They kind of smooth out those ruts, or they turn on other neuronal areas of the brain and basically allow you to navigate through your neural pathways in a different route than you were taking before. Hopefully that doesn't end in the destination of being depressed. And
they're like creating new roads in your brain.
Yeah, and so basically if you look at a brain on an fMRI scan, or you look at all the connections, your normal connections are X. Whenever you're on psychedelics, it's like 10X. And so you have a whole bunch more potentiality during the actual trip. But after the trip is over, that gets rapidly kind of pruned. And so that integration period right after a psychedelic experience is really critical, because we want to instantiate those neural pathways over your previous neural pathways.
What is it? What do you mean by an integration afterwards?
Yeah, so that's where we take basically the observations we had as an observer during the trip, and we ask the patients about how they experienced it, and we try to stitch together what kind of insights and things they found during those experiences, and how that's going to change their physical behaviors or their lifestyle behaviors, what they're doing after the experience. And that's typically done the day after a psychedelic experience with the classical drugs. With ketamine, some patients will elect to do that the same day when they do psychedelic-assisted psychotherapy with ketamine, because it's a shorter drug. It only lasts about 2 hours compared to 6 to 8 hours with some of the more classical hallucinogens.
So if we could focus on now for the next question is, what is currently approved by the FDA? That's ketamine and S-ketamine?
Those are it. And IV ketamine doesn't technically have FDA approval for depression. That's off-label, so really it's just S-ketamine. And then, like I said, MDMA, all the information has been submitted to the FDA. We're waiting on them to approve that. And last I heard, it's going to be around Q3 this year, so August, September.
How do you administer ketamine and S-ketamine? Yeah,
so ketamine depends on where you go in the country. So some places use oral lozenges. There's a company called Mind Bloom that does that at home for patients. Other places will do IV infusions or intramuscular injections. For S-ketamine, it's just a nasal spray. So you literally take it, shoot it up into your nose like you would with Flonase or other nasal kind of corticosteroids or nasal sprays, and we do that. We do 2 or 3 doses of the S-ketamine, and then patients are kind of monitored for up to 2 hours in the office. For some of the other ketamine locations, like I said, some places do it at home, some people do it in the office or in like group settings. It's a kind of a wild, wild west with ketamine derivatives as opposed to S-ketamine.
Is this ever a first line of treatment for depression, or is this only, okay, if nothing else is working, this is your last? Yeah. Your Hail Mary? Yeah, so S-ketamine, because it is insurance and FDA approved, we have to go through like a checkbox of saying, hey, you failed this treatment, you failed therapy, you failed another augmenting medication. And so that's pretty far down the algorithm. Most people have to have failed 2 to 4 medications during the current episode. For IV ketamine, given it's off-label and it's cash only, you could theoretically do that at any point. I wouldn't necessarily recommend that because, again, it's usually much more pricey than Prozac or Lexapro or some of your regular antidepressants that are probably going to work
40–50% of the time anyways, and normal depression is somewhat cyclical, and so you may just be having an adjustment reaction to a difficult time. And so you really want to work with your psychiatrist or mental health provider to kind of figure out, is this a more long-standing depression, or is this something that's going to kind of resolve itself in a couple of months?
So we have the trip, the very first effect known as the trip. That's what most people think of when they hear psychedelics. But then you've talked about the after effects and how it's important to follow up the day after or immediately after. And would that be considered talk therapy, where you're sitting there talking to the person about what they just experienced? Yeah,
so there is a semi-structured environment for integration therapy. So the beautiful thing about integration therapy is it's all about how the patient experience was during that trip. And so what they encountered, what made them afraid, what made them, what realizations did they have, and so how do we utilize other avenues of psychotherapy to help them do that? So some of it may be more psychoanalytic or psychodynamic, where we kind of walk through their life cycle. Some of it may be cognitive behavioral, like, hey, how do we actually institute this behavioral change? Some of it may be like motivational interviewing, like we would do for patients that need to quit smoking or stop drinking. So we have a whole bunch of psychotherapy tools that we can use. The integration session lets us kind of pinpoint, like, hey, what tool would be appropriate for this particular intervention now that the patient has reached a place where they actually want to make a change. And so I've heard it best described that psychedelics are like 10 years of therapy in 8 hours. And so you can hopefully get to a place where it's much more fertile soil for them to kind of go in and implement some of these psychotherapeutic changes.
That would save a lot of money.
Yeah.
Did you say 10 years of therapy?
Yeah, that's like 10 years of therapy in 8 hours.
So how long does the trip last? I'm trying to envision it in my mind. A patient takes the ketamine. Do they lay down on a couch? Do they sit there surrounded by a team of medical professionals? And how long does it last? And what does it look like?
Yeah, so each drug is different. So ketamine, we actually, when we do esketamine here at the health system, it's a 2-hour-long experience. We usually do that in a group setting. So we'll treat up to 6 people simultaneously without.
Are they sitting on chairs?
Recliners.
Recliners?
Yeah, they're like hospital grade recliners, so they actually recline all the way flat if people want to lay down. Other people just want to kind of kick their feet up and just kind of listen. We do play music in the background. Patients can bring their own music if they want to listen to their own headphones when they come in. Lights are usually out. We usually kind of have just kind of floor lighting with a few lamps on just to kind of keep it enough to where we can see. And the reason we keep them here is because we're mandated by the FDA to do that. So we monitor vital signs while they're during intra-treatment just to make sure they're not having any adverse reactions to the medication. And then the drug's out of their system in 2 hours for ketamine. For all the other psychedelic drugs, you're talking at least 6 hours. So MDMA is about 6 to 8 hours. Psilocybin is about 6 to 8 hours. LSD is up to 12 hours. And then there's a drug called Ibogaine, which is out there, which is like 36 hours. So
36 hours?
Yeah, it could be quite long. It's actually being studied for opiate use disorder, but it's a very, very long-acting hallucinogen. And
that would be a long trip to monitor for someone, let alone for someone to be on that.
Yeah, so the implementation of these substances as they come out, that's why psilocybin and MDA were actually selected, because it's an 8-hour. Kind of fits into a natural kind of work day, but there are going to be drugs out there that come out, LSD and Ibogaine are kind of the two that are longer than that, and so we're going to have to come up with a different delivery model for those.
What does it look like when, so people are in recliners and they're all, if they choose to lie down, they can lie down. Are they talking? Do they ever get up and try to walk around? And do you have to kind of guide them back to where they are? How does that work? Yeah,
so we have patients that have to go to the bathroom during treatment, so we escort them in and out with nursing staff to make sure, because they are probably a fall risk when they're in that state, and so they're a little altered. Most of them don't talk. Every once in a while people will have an insight, and I'm in the room with them for the psychoactive component of the trip for the most part, so usually about an hour or so. And so if they have questions, I'll go over and I'll say, hey, what's going on? They'll write something down on their phone or scribble something down, and I'll make a note of that, and we'll ask them about them at the end of the experience or the next time I see them. We also give them kind of journals that they can kind of write down experiences for, and then we talk about that before their next session. Because usually if they're getting something that's productive from the session, we want to make sure that we're kind of focusing on that area. We don't want to guide the trip too much for them, but we want to kind of set up an environment where they can explore those things a little more, because they're usually meaningful. There's a famous quote that the thing you most want is in the place you least want to look, and so psychedelics kind of focus your attention in those areas and help you kind of grow.
So you treat patients in a clinical setting, but you try to make it as homey as possible. We have a picture of a different treatment center. It's typically sterile, yet homey.
Yeah.
You got couches and things like that. Why is that important?
Yeah, so the environment matters. So when we talk about psychedelic drugs, we talk about the mindset, so how the patient is thinking when they come into the treatment, and then we talk about the physical setting. And so the physical setting is as important as the mindset. And so obviously if I was doing this in a hospital room with a hospital bed and bright white lights, people are going to have a much more kind of intense or anxious ridden trip. And so we try to make it as comfortable as possible. So we do turn the lights down, we try to have comfortable chairs, or for Psilocybin, which is what that picture was showing, they're going to be there for 6 to 8 hours. And so they may want to lay down during that period, so a couch or blankets if they get cold. The person that it was in that picture could also see being worn eye shades, and so we do provide those to the patients too, where they can put eye shades on so they can kind of focus more internally. Some of them even, like I said, choose to use their own music, and they put headphones on, and so they're kind of more locked in than they are to just the general setting. And so, you just try to create a very kind of homey environment for the patient, so that it doesn't feel quite so sterilized or quite so medicalized, because you want them to feel comfortable, and they may not feel as comfortable, how we all feel when we're in a doctor's office. We're a little on edge.
Right. It's not, because it's not a natural experience to be sitting anywhere for an appointment. It just doesn't feel that way, so that's important. And you've seen some pretty remarkable results. Is there anything you can tell us about some of the results you've seen so far? Obviously without identifying any specific patients, but what kind of results do you see? Yeah,
with ketamine in general, we see great results. I see people that have been on 12, 15 drugs that haven't responded to anything else, and then they respond to ketamine, and it's great. MDMA is very promising. It looks to be 50, 60, 70% more effective than our best treatment for PTSD. And kind of the beauty of that is that PTSD doesn't really get better with medications. There's about 10% of patients that will improve lifelong on medications, but most of that comes down to trauma therapy, but trauma therapy is incredibly intense. And so patients really struggle to do that. And so being able to give them MDMA, allow them to do MDMA-assisted psychotherapy for the potential of getting over their PTSD, and we're seeing remission rates as high as like 70 or 80%, compared to just like 10 to 12% with meds alone, or maybe 20 to 40% with psychotherapy by itself. And so it's a very remarkable drug. And so I'm very excited for that one to come out, because PTSD is a really chronic problem that I think we've underdiagnosed a lot in society.
Right.
And so having a definitive treatment for it, as opposed to like, here's a medication to treat your symptoms, now you got to go do 12 to 18 weeks of trauma therapy, which may be some of the hardest therapy you've ever done in your life. I think this will be a very nice access point for a lot of people.
For many people, the first time they even heard of ketamine was in the news when actor Matthew Perry died. He did have a prescription for ketamine, but the autopsy was confusing to those of us not in the medical field, because it said he died from acute effects of ketamine. You didn't treat him, but what does it mean that he had this prescription and then he died from acute effects of the thing he had the prescription for? Yeah, so from what I recall, in the articles that were written about it, so he was getting ketamine infusions, and his last infusion was like a week and a half prior to his death. So that would not be from the direct effects of the ketamine infusion. That's out of your drug within a couple of hours. Like I said, a ketamine infusion, you're going to be back to normal usually within 2 to 4 hours. It's going to be out of your system usually within 6 hours. So we know it wasn't from the ketamine infusion. They actually found it in his stomach, which makes me believe that there was probably an oral ketamine that he was given. Oral ketamine is not something we prescribe here at KU. It's not something that I believe is very effective, but there are clinics, especially in California, that will prescribe oral lozenges, or there's actually a tablet of ketamine that you can get. And so just by complete conjecture, I suspect that somebody had given him oral ketamine, and I believe he was using it in and around a hot tub. And so ketamine has opioid properties, especially when taken orally, and can cause dissociative symptoms. And so it's quite possible that he may have been in the hot tub, taken the ketamine, and that may have resulted in his cardiac arrest that happened. So definitely different than the infusions that we would be seeing. So. Well, that illustrates the point you're making, is that these drugs can be incredibly beneficial, but they have to be used under the right guidance, with the right dosage, with monitoring, and that illustrates your point. It was really so sad. It really opened a lot of people's eyes to this kind of therapy being available, and how to use it, and what happens when you don't use it properly. If that was the case. There are more ketamine clinics popping up. What are some of the red flags or green lights that people need to look for when they decide this might be something they want to explore?
I would say the Matthew Perry thing also highlights the risk we have of like wide-scale public use of it. Like again, if you're not using it in the correct setting, we're going to find ourselves in like a 1970s situation, or 1960s, 1970s kind of situation again, and that's not what we want, because we don't want a severe backlash to limit the use for the people that actually need it. And so, to your point, there are several ketamine clinics across the city, a metro area, and then across the country that are out there. And so, I really recommend that if they have a psychiatrist on staff, that's probably something you're going to want to look for, who is experienced in mental health. A lot of these ketamine clinics are ER doctors or anesthesiologists who are familiar with ketamine but in a different role. So they're using it for intubations, they're using it for medical procedures, and so they're using doses that may be higher than you need. And so having a psychiatrist at least there for consultation, even if they're not the ones doing the actual prescribing of the ketamine that you meet with, is something that I would definitely look for as kind of a positive indicator. If it's more just like, hey, come in, we're going to dose you to this ketamine, I think in certain circumstances that if that's all you have, that may be fine, but we really want to make sure that you're getting your mental health evaluated as well as all the medical issues that go along with ketamine too. And so that's the real thing to kind of look into, is whether they have a psychiatrist on staff and a psychologist, ideally, that you can hook up with, or establish with a psychologist before you go in to do that, because there are going to be things that come up during those ketamine experiences that maybe an ER physician or an anesthesiologist isn't as equipped to handle, and so having an outlet for those types of things is really important.
So ketamine is the present. We have lots of questions about the future for you, including MDMA and mushrooms. We're going to get to those questions in a minute, and we're going to get to your questions, so be sure to ask them. You can use the chat function on YouTube or Facebook. You can reach us on the X platform, or you can email the Medical News Network. All the information and how to connect with us is right there on your screen. And while you send in your questions to us, we do want to update you on the COVID count as well. As of Monday, we had, we had 11 active cases in the hospital, including 4 in the ICU, and one of those patients on a ventilator. The total number we are showing you right now tracks with what we've seen for the past few weeks. We're really hoping to see that dip down into single digits soon. So back to our discussion with Dr. Tyler Chervestad. Clinical trials are underway for MDMA and Psilocybin. Can you explain what is MDMA? Because I think 90s raves, a club drug.
So MDMA was a club drug. It was classically called Molly or ecstasy. Those drugs were probably contaminated with another drug called MDA, which is much more like a methamphetamine derivative stimulant. And so basically the difference between MDA and MDMA is that MDA is more of a stimulant like you'd think of Adderall, Vyvanse, methamphetamine. MDMA is a serotonin releasing drug, or what we call an empathogen. And so why it's so helpful for PTSD, or why it's being studied, is it basically causes people to feel more positively towards themselves and towards others. And that's really blunted in PTSD. People have a lot of numbness, depressive symptoms, they kind of get down on themselves, and so MDMA basically improves their ability to experience empathy and positive emotion. And so it's doing that via a serotonin mechanism as opposed to a stimulant mechanism, which would be norepinephrine or dopamine that you'd get from like methamphetamine or Adderall.
So when could MDMA be up for approval?
So we're hoping by August or September it could be approved, and then production would probably take several months. So for actual prescribing and in-office use, December, February, we're making plans here at the health system to have that ready to go as soon as we can.
Right around the corner.
Yeah.
What about psilocybin, the ingredient in magic mushrooms? What does psilocybin treat?
So the studies on psilocybin are pretty vast. So the most advanced study is on treatment-resistant depression. Again, that'll probably be 2025, late in 2025, early 2026 that we're expecting that. But psilocybin's been studied for smoking cessation. It's 2 to 3 times more effective than our current smoking cessation treatments. It's also being studied for OCD. Probably the most promising one that I'm hopeful for is anorexia, because we don't have an actual treatment for that. And so they're studying this to see if it could actually be a definitive treatment for anorexia.
How would it treat that?
So hyper-rigid conditions, so OCD, depression, anxiety, PTSD, basically things where those neural networks are really, really instantiated, and OCD is probably on the extreme, anorexia and OCD are on the extreme end of that, where you have really, really rigid kind of thought patterns about things. Psychedelics are great for that. They're not great for kind of chaotic environments, so schizophrenia, psychotic disorders, mania, because you're just adding chaos to chaos, and so you're not getting anything. But whenever you drop a little bit of chaos into like an ordered system, you actually might be able to find a better solution to that. And so anorexia and OCD are really difficult to treat conditions that I think would respond really, really well to psychedelic drugs.
Boy, that's fascinating. And without psychedelics, it would be the standard treatment options.
Yeah, and so that's the other appeal of psychedelics in general, right, is would you rather take a medication every day for the rest of your life that has a lot of side effects to it, or for 9 to 12 months on the short term, and you're going to get a lot of side effects from it, or would you rather come into the office and do 2, maybe 3 treatments, possibly for lifetime, but maybe it's once every couple of years or once a year, and then you don't have to take a medication for the rest of that year. And so you only have the side effects in and around dosing. You don't have to have continual exposure to the medications over the course of a year and have all the side effects that go with it.
We're getting plenty of questions from our viewers, so I want to get straight to some of the questions that are coming in on Facebook. And Jeremy Yenser wants to know, are there risks of or counseling to prevent things like patients who experience this in a controlled setting from trying to repeat it later on their own? So if someone has such a great time, great experience with you, how do you keep them from repeating it on their own?
Yeah, there's a lot of education that goes on with psychedelic drugs, and so we basically want to make sure that patients are aware that, we're going to take the utmost precautions, so tapering you off any of your regular antidepressants or anti-anxiety medications that might counteract or negatively interact with the psychedelic drugs. So that's the most important thing, but also that we have quality control. So that's the main thing that the medicalization model provides us, is that when we tell you you're getting MDMA, you don't have to worry that you're getting MDA, or you don't have to worry that you're getting fentanyl or other medications. And so that's the real problem in this day and age, is that a lot of the drugs that are being given out under a certain name are not actually that drug. They're contaminated with other things, and so you can't be assured that the quality is there. And so that's probably the biggest pitch I have to patients that say, don't go do this on your own. A, it's illegal, but also you want to be very, very safe. And with fentanyl being just so prevalent now, we don't want you to overdose on something that you thought was going to be very helpful, and it turns out it just kills you.
It's one grain of sand size of fentanyl can kill you. It's so scary today with fentanyl out there. Perry wants to know, do these drugs interact with other drugs I might be taking? Do I need to stop any medication before using psychedelics?
Yeah, so the classical hallucinogens, psilocybin, LSD, mescaline, and then MDMA, which is a serotonin-releasing drug, all of those require you to be off all serotonin-modulating agents. So your typical antidepressants, you have to be off those at least 2 weeks. In the case of like Prozac, you have to be off that for a month. And so that's a really tall task for most patients, especially if they have some stability. Ketamine may be a better option for some of those patients because it does not modulate serotonin directly, and so you can use ketamine with your regular antidepressants. And so, depending on what drugs you're on and what you're on them for, sometimes it is appropriate just to do more ketamine in that sense because you don't have to stop everything. But for patients that are really refractory, we're probably going to do a washout, and that may require even a psychiatric hospitalization to monitor them for safety.
While they're weaning them, while they're
off.
Taking off, stopping the other stuff like their Zoloft or the Lexapro, things like that.
Yeah, so they may need to be medically observed during that period, or psychiatrically observed, just to make sure that they're not suicidal or not requiring higher levels of care.
Jim emailed us. He wants to know, what about LSD? Is LSD being studied?
Yeah, so LSD actually just got approval for generalized anxiety disorder, first drug approval by a company. It's an LSD synthetic derivative, so it's not quite LSD, but it's very similar. That just happened a couple weeks ago, and so they'll be looking at that for generalized anxiety. One single dose of this compound, and the generalized anxiety was in remission for, it was north of 60% of patients, and so they'll be moving to phase 3 trials eventually.
I have a question. Do you find that certain generations or age brackets are more open to this than others? Like growing up in the 70s and 80s, it was really ingrained into me, psychedelics and acid, and that's bad, bad, bad.
Yeah.
Do you have people from different generations that aren't open to it?
Yeah, I think the younger generation is much more open to it. They've come up, there's been less scare tactics. The older generation, there are a lot of them that actually use psychedelics, and I'm surprised every time I ask. They just didn't talk about it a lot.
Oh,
and so they had a little bit more experience. So I think it's definitely that kind of Gen X generation that's right there, where they got all of the fear mongering and they didn't get any of the potential benefits, or they had all of like the club drug kind of stuff, and they didn't see the therapeutic potential for it. But by and large, I think they've done surveys on this. 40 million or 50 million Americans have probably tried psychedelics, and in a country of 350 million, that's a large potential. So you probably know somebody that's used them. They just have never really talked about it. And so again, when they're used appropriately in the right setting, under the right circumstances, and the right mindset, they're very, very helpful. But outside of that, they are, like I said, abusable. And so you want to be very thoughtful about that.
And that's what I want to just get to Bonnie's question. Bonnie wants to know if psychedelics can ever trigger a bigger mental health problem.
Yeah, there are definitely certain patients that we would not recommend using psychedelics. Obviously, if you have a history of schizophrenia, bipolar disorder, although we are studying bipolar depression in certain patients, for ketamine use right now, and so that may budge a little bit. But definitely those more disordered kind of conditions, those are the ones we worry about. Because again, if your brain is already, it's not rigid at all. It's just kind of flight of ideas. You've got a ton of chaos in the brain. Introducing something that's going to destabilize that further is probably not going to be helpful. And so most of the clinical trials rule out even patients with a first-degree relative of psychotic symptoms, schizophrenia, and all of that, just to be extra safe. The evidence on whether it triggers psychosis is pretty limited, but we are doing that out of an abundance of caution. So,
when it comes to today's takeaways, this is a fascinating discussion. I could keep you here for another hour peppering you with questions, but I know you have patience. What do you want people watching to know? Yeah,
I'd just say that there are better treatments coming down the line, and so if you think that we could be of help, you can always reach out to us or look on the health system website. We have a treatment-resistant depression clinic that all of these substances are eventually going to be folded into, and right now we have ketamine and a few other interventional procedures that we can use as kind of a stopgap measure until some of these other drugs come out.
Thank you so much for joining us today. This is a fascinating discussion, so much to think about. We really appreciate your time.
Yeah, thank you.
And thank you to our viewers for being with us today. We will see you right back here tomorrow morning.
Nanotechnology implanted in the brain and spine. Remarkable research is letting paralyzed patients walk again. I'm Jessica Lovell on the next Open Mics with Dr. Stites. The blurry boundary between what's your brain at work and what's technology. Meet the researchers teaching AI to decode your thoughts, Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.